just want to review I like to call it stage reperfusion, and again, we're just focusing on the anterior circulation here. I know you just reviewed the guidelines, so it's kind of perfect timing, so we won't talk too much about the individual trials. And I have some cases here that we'll talk about. The one thing that's really sort of the key factors in the cognitive process of deciding who is a patient for thrombectomy after IV TPA, obviously last time normal. Currently, as we just found out from the guidelines, it's recommended, obviously, that we have a 3 and 4.5 hour window for TPA. We now have a 6-hour groin puncture time. So it may be difficult to do. It may be difficult to do if you have somebody right at the 4.5 hour mark at night. Obviously, there's wiggle room on that. Age, as I'll show you, plays a role in patient selection. Medical comorbidities, including the baseline neurological modified Rankin scale. And then there are radiographic factors that have to be weighed into the decision, including core infarction volume and location of arterial occlusion. I think, just to refresh your memory, modified Rankin scale is a measure of function, not physical deficit. And 0 is no symptoms, 6 is death. In all trials looking at stage reperfusion, a modified Rankin scale of 2 or less was considered a good, favorable outcome. 2 is slight disability. 1 is no significant disability despite some symptoms residual from the stroke. Once you get 3 and above, you're getting into the realm of moderate disability. Now, one of the clinical scales that I like to use is the Thrive score, which helps you delineate what the potential outcome from thrombectomy might be. Now, it's never been looked at in terms of stage reperfusion, but there are retrospective studies looking at outcome from TPA and also from thrombectomy alone. And it's a 0 to 9 scale that weighs into the baseline NI stroke score. The higher the NI stroke score, the more points. So you can see it's obvious that somebody who's greater than 21, less likelihood of better outcome from a thrombectomy. And it kind of goes along with core infarct size as well. Age plays a role. Under 60, good. Above 80, less inclined to have a favorable outcome. And then we have clinical medical factors. These are premorbid diagnoses of AFib, diabetes, hypertension. AFib, probably in large part because the emboli tend to be larger, and hypertension and diabetes, probably in part because they have poor collateral flow, they have more diseased arteries, and we know that diabetics may, especially if they're hyperglycemic, have a slightly higher risk of bleeding in the brain. So I like to use that as a tool. This is the a publication from last year looking at how the Thrive score predicts outcome in patients treated with a solitaire device in the SWIFT and STAR trials. The trials were kind of a device trial. I think in the SWIFT trial there was some patients who got Mercy, some who got solitaire. The STAR trial was primarily solitaire. And you can see that the increasing Thrive score strongly predicts a decreasing chance of good outcome, with a Thrive score of 0 to 2, predicting a pretty good outcome. And this is just thrombectomy alone, whereas it's moderate with a 3 to 5. And once you get to 6 to 9, there are patients that improve, but you can see the likelihood of a good outcome diminishes. Now, death also, you can see that Thrive does predict the risk of death in 3 months from the stroke following the procedure. And again, This 6 to 9 sort of portends a poor prognosis. So somebody with a score of 6 to 9, you've got to weigh that into consideration when considering stage reperfusion. Core infarct volume can be measured by DWI and also the aspect score. DWI, once we see DWI on an MRI, it's important to understand that it's usually not reversible. It's dead tissue already. The Diffuse 2 trial was a trial that looked at thrombectomy in patients with stroke, and I think all patients underwent an MRI prior to the procedure, and early DWI reversal occurred in about 1/3 of patients after endovascular therapy. However, it was often transient, and it wasn't associated with a significant volume of tissue salvage or favorable clinical outcome. The median volume of permanent reversal at 5 days was 3 milliliters, which is small, and only 3% of patients had a final infarct volume that was smaller than their baseline DWI. So what this says is that you may see small changes in DWI after an endovascular procedure in a minority of patients, but it doesn't influence clinical outcome. So on that acute MRI that you do, that DWI volume is probably irreversible. Why do patients get better then? Some patients get better. Well, it's probably that zone around the DWI. If there's a penumbra, there's tissue that's oligemic, being perfused in a reduced fashion, but the neurons and axons are still alive. But if persistent oligemia goes on, they'll die. So you understand that concept. DWI probably is not reversible in most patients. The goal of stage reperfusion therapy is not to eliminate that bright white spot of DWI. It's probably to protect the tissue around it. The other interesting thing, too, from a volumetric assessment, I mentioned that volume does play a role in predicting outcome for both TPA and thrombectomy. And previous studies have shown that infarct volume is associated with clinical outcome. And not surprisingly, larger DWI volumes are associated with poor outcomes, and that kind of correlates with your Thrive score, with the United Stroke score. The higher you go, the more points you get. A final infarct volume of 90 cc's has been shown to be a highly specific cutoff value for identifying patients with poor outcome. And this is the data from the Mass General experience, whereby the bar graphs depict outcome. On the bottom here we have infarct volume in cc's, and the percent of patients. These are the number of patients who had the core infarct volume here. These are patients that underwent thrombectomy. There were some that underwent staged reperfusion, but you can see that nobody had a favorable outcome, an MRS of 0 to 2 if their infarct volume was above 120 cc's, and only a small minority, 33%, had a favorable outcome if their core infarct volume was between 91 and 120 cc's. So that patient that we see in the emergency room with a core infarct volume of 150, 200, the horse is already out of the barn. Now, they subdivided this into patients under 80 years because we know age plays a role. You can see there's a little bit of a shift. 42% of patients with an infarct volume of 91 to 120 had a favorable outcome. 80% of those with 0 to 30 versus 68. But again, nobody in this range had a good outcome. So notice that your best outcome is in those with 0 to 30. Although you're probably not going to go after anything if somebody's 0, but you will have patients 25, 30 with an M2 occlusion or distal M1 occlusion. Those are probably the ones that have the best outcome. The aspect score I think you're familiar with, so we could probably skip over that, right? You're familiar with that now. when you do the aspect score, the key thing is to remember you are allowed to window. When you're looking at the CAT scan first for an early hypodensity, the one that excludes a patient from TPA, right? An early hypodensity more than a third in the MCA, that you don't window, all right? That's just on regular windows. But to calculate the aspect score, you window it and look for that dark black gray sort of patch. So what's interesting is aspects also independently can predict outcome from stroke, probability of an excellent outcome, MRS of 0 to 2. Generally, if it's 6 or above, you start to get into the better outcome ranges. And we know now that 6 or above seems to be a cutoff. I'm not going to go through each of these studies just because I think you're familiar with them now. And I think you're probably familiar with this also. Arterial occlusion is important. Generally, we think about doing a stage reperfusion if there's an ICA occlusion and one occlusion. M2 becomes patient selection. I think also distal M2, very distal M1 also becomes a little bit, you really have to select your patients appropriately. So you probably are not going to do the procedure on an 82-year-old here with AFib, diabetes, hypertension, because of age, higher Thrive score, lower propensity to respond to the outcome. I'm going to skip over this because we kind of talked about that today. And I think you understand the difference between a stent retriever and the old one, so we don't have to go over that. I put this slide in just to remind me that there are special circumstances when you have a patient with a large MCA. This is dead tissue. This is probably 200 cc's. Previously, we were enrolling patients in the GAMES trial. Just to let you know the status of that, they are doing an analysis now. The study's on hold. They're analyzing the data. And we are supposed to know August 1st. The analysis, remember this was a phase 2 study. Phase 2 studies are primarily designed to look at safety, with outcome being a secondary analysis. If it appears that it's safe and there is a trend towards better outcome, they will likely move to a phase 3 study. This is important. This is an important area because these are patients that don't respond to bridging therapy. And remember that patients could get into the GAMES trial with or without IVTPA. So it'll be real interesting to hear if we can move into a phase 3 because this is a segment of patients with middle cerebral artery infarction where currently we have nothing really to offer them. At our site, and if you remember what's interesting in the GAMES protocol, patients were eligible if the volume was above 83 cc, so it kind of correlates nicely with the slide that I showed you with respect to poor outcome if DWI is above that volume measurement. And as we talked about this morning, ICA occlusion in the stent retriever trials, patients could get into the studies if they had an ICA occlusion. It's a technically more challenging procedure because you got to navigate your wire through an occluded artery. The occlusion extends up to the ophthalmic artery, and then you got to go get it with a stent retriever. Sometimes what they'll do is they'll remodel this as they go up with angioplasty. It adds time to the procedure. There's a risk of reembolization. I think what's going to happen is each institution is going to have to decide if they want to exclude or include patients with ICA occlusion
for intervention.
For intervention, yeah.
So do we include them in our right now?
Well, we're going to have to, I think, in light of the guidelines, I think we're going to have to meet with Dr. Siragusa.
Okay.
You may find that some of the attendings don't want to, some may. It may be attending dependent, which is okay. These are tricky cases. So, that's that. This is my one stroke cartoon. So let's just take a look at a couple cases. So this is case one. A 58-year-old man. Last time normal was 2 hours ago. He has an expressive aphasia and right lower facial weakness, plegic right arm, NI stroke scores 11. No medical contraindications for TPA. Doesn't have a history of hypertension. So, kind of what I like to do is just calculate his Thrive score here. So, it kind of helps you.
So his Thrive score is going to be NIH is 11. That's 258. 0 hypertension. His Thrive score is 3.
Okay, so he's in that mid-range.
Right.
If you look on the back here in the card, we have a chart there, and he's sort of in that mid-range.
Right.
He's not 6 to 9. I get a little more worried if they're 6 to 9. So let's take a look at his. Let's take a look at his MRI. I guess I gotta end it. I can't minimize.
Just escape.
Yeah. So here's his baseline CAT scan. You might see a little hypodensity here, but it's a tough call. And when you do the aspect score, you just window it. But it looks kind of symmetric. I mean, if you gave him a point here, I wouldn't argue. And let's look at his MRI. What's interesting is you can see a little bit of an early change on flare. Maybe that was on on the CAT scan. We may have seen, the basal ganglia is very susceptible to ischemia because it's all gray matter. What I can tell you is this measured 68 cc's, and you kind of got what it looks like is more of a distal M1 occlusion because the internal capsule looks like it's spared. And then you have the lateral lenticular striates here being affected. The lateral come up into the central semio-valley. And here's his MRA. You can see here, sure enough, it's more of a distal M1 occlusion. So one thing to maybe read up is the difference between medial and lateral lenticular striates. The medial lenticular striates supply the internal capsule.
Yeah.
The lateral supply more centrum semio-valley.
It's AC and MC distribution too, right? The lateral is MC and the medial is AC.
Well, no, medial lenticular striates are off the medial part, the proximal part of the M1,
okay.
And the internal capsule. So you have the medial.
The AC is lateral. I know
the AC is Huebner's arteries. You don't talk about lenticular striates with the AC.
Okay. Yeah, I know it's Huebner's too, but
yeah.
It's lateral.
So what do you think? What would you tell the team on this guy? Dominant hemisphere, 68 cc's. Young guy, but more distal. M1.
Yeah, I mean, I would encourage him to do endovascular treatment.
Okay.
Just because he's got, he's a young guy. He's got expressive aphasia and meets the criteria pretty much.
Okay, I agree. Okay, and let's look at Same MRI, but we got an 83-year-old man, last time normal 2 hours ago. Expressive aphasia, right lower facial weakness, and a plegic arm, NIH is 11. No medical contraindications for TPA, but he has hypertension, AFib, diabetes.
Yeah, so it's,
And it's a distal M1. Distal M1.
yeah, so his Thrive score is going to be higher. In this
Yep.
case, it'd be 2 plus 3, 4, 5. NIH is 6, 7.
Right.
So yeah, it'd be 7. So
Right.
you know the trial showed that there was a poor outcome, a worsening of the outcome with a higher Thrive score. So be probably a little bit more reluctant to pursue it.
Right. And it's not a proximal M1 or a carotid. I mean,
Yeah.
you could say if it's the top of the carotid, maybe, but it's kind of distal M1. So you see, this is one where you gotta. This one, there's no right or wrong. You're kind of on the fence. You kind of got to weigh: was he functional before? Did he have a bad heart? I don't think it's wrong to hold off in this case.
Okay.
All right. I don't think it's wrong not to call in the interventionalist on this case. All right. Okay. Case 3 is a 58-year-old man, last time normal 2 hours ago. Right gaze deviation, left hemiparesis, NIH stroke score 12, no TPA contraindications. He has a pacemaker and a history of diabetes. How are you going to handle him?
So it's 58 last time. So pacemaker, history of diabetes. Alright, so he's NIH is 12, which is 2, less than 50, 0, diabetes 3, so he's 3. This is Thrive score. Where's the lesion?
He's got a right hemi. He's got a right gaze deviation, left hemi, so it's right middle cerebral artery.
Yeah, but it's like proximal distal M1.
Well, how you gonna? Yeah. Let's assume. See, you can't do a pacemaker. He has a pacemaker, so you can't do an MRI. So how are you gonna kind of assess?
All you can do is CTA.
Right. Let's say it's a proximal M1. How are you gonna assess the infarct size?
Oh, you have to do the aspects.
Right.
Yeah.
So it depends a lot if it's 7 versus 4. So this is just a case where you're going to really have to go back to your baseline CT and just, wheel it. All right. Case 4, 48-year-old man, last time normal 1 hour ago, mixed aphasia, right hemiparesis, NIH stroke score is 18. No medical contraindications for TPA. Let me put his MRI in. So here's the head CT. This is an interesting case. Just tell me.
Yeah, one side.
You see the hyperdense sign there? So remember there were some people who used to say, oh, it's a hyperdense MCA, we got to bypass TPA, let's go get it. Right? In Chartail, you remember people talking one thing. Would you still treat him with TPA?
Yeah.
Okay. Treat him with TPA. He's got a hyperdense MCA. And let me show you his CTA. obstruction, but you can see he's probably got, it's tough to see here.
You just probably R1 would be the best.
Yeah.
The fourth one.
Let's see if that one goes. I'm not sure that's the head.
Oh, you're looking for
Yeah, there we go. So it appears that the middle cerebral is filling here,
Yeah.
but it may be coming from the ACOM. See that?
Mm-hmm.
And what I think he has is the top of the carotid occlusion.
Oh, yeah. I don't see the carotid overlaps.
Yep. And maybe here you can kind of pick it out. It's probably going out the ophthalmic here. Right here. Alright, so, you could say he's got collateral flow, but, he's got the top of the carotid occlusion, so you're going to want to do your MRI, right? What do you think? Volume is 214.
Yeah. Probably stay away from that
Yeah.
intervention.
Yep.
Probably Games trial candidate.
It's so hard when you're down in the ER, and you have these patients. You have, I just want you to know there's going to be pressure on you to do it. All right, hyperdense MCA, 48-year-old. Mixed aphasia, right hemiparesis. But the likelihood of any good coming from it is probably nil. This is dead tissue, and the likelihood of doing harm is not, probably obviates any potential small benefit. As I showed you, if you just remember that graph, under the age of 80,
Right.
above 120, nobody has a favorable outcome. So these are tough cases. These are ones where if radiology gets their hands on it, Siragusa sees it, he may say, I can do it. I can do it. They're kind of looking at more at the pictures
Right.
rather than the clinical scenario. I don't think it's wrong. And Dr. Glassner may say, let's do it. We got to do it because he's going to be accepting the patient. So this is one where you've really got to kind of be the voice of reason. And I don't think it's wrong to say no. The horse is out of the barn. I label him as being 48. He's really 63. I just put that in for educational purposes. But, I think if the family wanted everything done, this is where you got to kind of convene with, Dr. Rauer, Dr. Sandu, talk it over with the interventionalist. You got to say, the volume is this. I know the chance of a good outcome is nil. Technically, do you think you can do it? And they'll say yes. I can get that easily, but you've got to say, is it really going to help them? All right. So this is where you're really going to have the discussion, with the team. Try to get everybody on the same page. If the family's, and this might be a case if he's 45, 48, you kind of present the information to the family. We can't guarantee anything good is going to come of it. It may be harmful, but if they say, I don't care, do it, it may be enough for the interventionalist, to do it. All right? So this is a tough one. All right? You got it?
Got it.
So, I'm just going to conclude that, proper patient selection is the key. All right? That's what your role is. Proper patient selection. It's not everybody with an MCA occlusion. It is key when deciding to utilize a stage reperfusion approach to treating a patient with an anterior circulation ischemia. Advanced imaging will need 10x greater than equal to 6. Consider associated clinical factors, which the Thrive score helps you with. Look for an ICA, M1, or M2 occlusion in selected patients, M2 occlusion. And these are the kind of cases where, when you're in the ER supervising the residents, these are all the moving parts,
we got to take into consideration.